Good morning, everybody, and welcome to this week's clinical meeting. Warm welcome to all of you. The first case for today will be presented by Dr. Christina from Medicine 4, and it's titled COND.
Man from West Bengal. He presented with complaints of episodic weakness of the bilateral upper and lower limb over the past 2 years. He was apparently well until November 2022 when he noted intermittent weakness of his limbs, trunk with no specific pattern over the past 2 years. He's had six such episodes, each lasting for about 5 to 6 days to a maximum of 9 days. Each time it was precipitated by a physical exertion. It usually resolves with almost no deficits. In between, he was able to do all his activities except for minimal squatting. There was associated cramping type of pain. So this was his timeline. It started in November 2022 when he developed heaviness and weakness of both his upper limb, followed by lower limb. The onset was precipitated by carrying heavy baggage. So this resolved in 3 days. He did not take any treatment at this point. In March 2021, he developed buckling of knees while walking. And after reaching home over the next 3 days, he developed difficulty in turning from side to side, went on to develop drooping of head, which improved over a period of 6 days. At this point, he was dependent for activities of daily living. So he was taken to a local hospital where his blood pressure was noted to be 200 by 130. His MRI done there was verbally reported to be normal. Then in May 2021, he had a similar episode which was precipitated by running, where he was managed locally with oral medication. In November 2021, again it was precipitated by walking, where he was treated with IV fluids and probable neurobion injections at that point. So in March 2022, when he did not have any complaints, he had presented to Apollo for evaluation of this. We don't have any treatment details, but at that point, he was noted to have a potassium of 2.3. His TSH was 2.1, and his nerve conduction study done at that point was normal. Following this, he had another episode in September 2022, after which he presented to us in November 2022. Past history: he's a known hypertensive for the past 3 years. Uh, it was incidentally detected during a regular checkup. He was treated with telmisartan, metoprolol, amlodipine, and hydrochlorothiazide. Personal history wise, he consumed a mixed diet and he had no addictions. Family history: his father was a hypertensive, diagnosed at after 50 years of age. Going on to examination, he was conscious and oriented. His pulse rate was 80 beats per minute. His blood pressure was 150 over 70 in both his right and the left upper arm in the supine position. His left lower limb systolic BP was 160 millimeters of mercury. Respiratory rate was 18 and was regular. He was afebrile. There was no palaictus, cyanosis, clubbing, or lymphadenopathy. Cardiovascular system, per abdomen, and respiratory system examination was normal. Going on to central nervous system examination, his higher mental functions were normal. Cranial nerve system was unremarkable. His motor system examination showed that he was hypotonic in both his upper and lower limb bilaterally, with features of weakness in the proximal muscles in both the upper limb and lower limb, especially in the shoulder joint and in the hip joint. Reflexes: his superficial abdominal reflexes were absent. Deep tendon reflexes: his bilateral biceps, triceps, and ankle joint were absent. There was no cerebellar or meningeal signs. Skull and spine examination was normal. So, summarizing, we have a patient with recurrent episodic proximal muscle weakness, predominantly proximal muscle weakness, involving both the upper limb and lower limb and the neck muscles and trunk muscles, along with an uncontrolled young onset hypertension. The differentials, any differentials? You can put in Slido. The code is 5536343. Okay, going back. So the differentials we had considered were endocrinopathies such as primary aldosteronism along with hypokalemia, Cushing syndrome, hypokalemic periodic paralysis, thyrotoxic periodic paralysis, drug-induced any drugs causing paralysis, atypical neuromuscular junction disorders like Lambert-Eaton syndrome or myasthenic variants, any channelopathies involving the calcium or the sodium channels, or multifocal demyelinating polyneuropathy. So going on to investigations, his blood counts and everything else was normal. He was noted to have a potassium of 1.6 at presentation. His ABG had shown a metabolic alkalosis, pH of 7.45, with PCO2 of 29.7 and bicarb of 39. Other investigations such as TSH was normal, his ECG was normal, and his EMG NCV was also normal. So at this point, we considered the probable diagnosis of a Conn syndrome. I would like to speak briefly about Conn syndrome. It is the cause of primary aldosteronism. It's the most common form of secondary hypertension. It causes more endocrine damage and is associated with excess cardiovascular morbidity, such as heart failure, stroke, non-fatal myocardial infarction, and atrial fibrillation. The screening for this is simple and is readily available. The targeted therapy improves the blood pressure control and mitigates the cardiovascular morbidity. However, despite this, the screening rates continue to be low. The two most common causes of primary aldosteronism are aldosterone producing adenomas or a bilateral adrenal hyperplasia. So this is the pathophysiology. This is the normal RAS mechanism. In hyperaldosteronism, there's an excessive of aldosterone secreted from the zona glomerulosa of the adrenal cortex, which acts on the renin, which has a negative feedback on the renin production, and thus there is very decreased amount of renin produced. So because of increased aldosterone, there is increased sodium retention along with water retention also is there, which leads to volume overload and hypertension. To compensate for the sodium retention, there is loss of potassium and hydrogen ions, which contribute to the metabolic alkalosis and hypokalemia. So the clinical features as mentioned are hypertension, hypokalemia, metabolic alkalosis, muscle weakness and arrhythmias which are related to the hypokalemia, and polyuria. If a patient has hypertension and hypokalemia, or hypertension and a family history of early onset hypertension or a CVA at a young age, or hypertension and they have an adrenal tumor, or controlled blood pressures with more than 4 antihypertensives, or a sustained BP of more than 150 over 100 measured at 3 different days, or if they have hypertension and sleep apnea, or all hypertensive first degree relatives of patients with primary aldosteronism. Going on to evaluation, the screening is usually done with the plasma aldosterone concentration by plasma renin activity. It is a ratio. A ratio of more than 30 is considered significant. So when we order this ARR, the aldosterone renin ratio, we need to take into account the other drugs which can affect this ratio. Beta blockers tend to decrease the renin level and increase the aldosterone level, and ACE-ARBs will increase the effect of renin and decrease the level of aldosterone. Confirmatory test is either with an oral sodium loading over 3 days or a saline infusion test. To localize, we'll do a adrenal CT to see which side is involved. And if it's a unilateral involvement and the patient is more than 40 years of age, we do adrenal venous sampling. This is a flowchart from Harrison, where if you have a clinical suspicion of mineralocorticoid excess, we first screen for them with using the ARR test. We confirm using either a saline infusion test or the oral sodium test. And we do a CT to see if it's a unilateral, bilateral, or a normal adrenal pathology, and manage accordingly. I just want to highlight regarding the high prevalence and low screening of primary aldosteronism. This is a retrospective cohort study where they have studied 466 patients with resistant hypertension with ages between 18 to less than 90. From the year 2008 to 2014, they have noted that only 2.1%, that is only 97 patients, were actually screened for primary aldosteronism. This is another study done in Canada and Ontario. It is a population-based retrospective cohort study where they have seen the screening rate of primary aldosteronism among patients who had both hypertension and hypokalemia. So they had initially included 26,533 patients, of which only 422 had actually underwent screening for primary aldosteronism. We can see that over the years, the rate of ARR screening remains the same, nearly the same. This is another study done in India in AIMS actually, where they have looked at the high prevalence and the long delay in the diagnosis of primary hypertension. So they've included 202 young hypertensive patients, of which 38 patients were screened positive, and of which 36 of them were confirmed. So there was a time delay of around 10 years before patients were actually hypertensive for 10 years before they were screened for uh, primary aldosteronism. This is another study where in a single center, they have followed up patients. They have shown that there was a delay of around 7.2 years from when a patient was diagnosed with hypertension to when they were referred to a hypertensive clinic, and further delay at the hypertensive clinic, totaling up to 8 years before which the patient was diagnosed with primary aldosteronism. So going back to our patient's aldosterone level was 33, which comes to 3.3 nanograms per deciliter, and his direct renin, which is what we do in CMC, was 0.5. So in this algorithm, if we see, this is what we check. Our patient's ARR ratio was 6.6. We had gone ahead and done a CT abdomen pelvis, which showed a 19 size lipid-rich adenoma in the left adrenal, suggestive of an adrenal adenoma. Our patient had a relatively low aldosterone level. It was attributed to the concurrent administration of ARB that he was on. So our patient was started on potassium corrections, spironolactone, and other antihypertensives, following which all his motor deficits had completely resolved. His areflexia also resolved. He was seen by endocrinology and endocrine surgery, discussed in the MDT, and he's planned for surgical resection of the adenoma in the coming month. So the take-home points, I wanted to talk about the prevalence of the primary aldosteronism. In a hypertensive patient with unprovoked hypokalemia, the prevalence is nearly 40 to 50%. We need to have a high index of suspicion to screen for the disease. I wanted to talk about the indications for screening and the ARR and how to send. Thank you.
Thank you, Christina. I think that was a very interesting presentation of a simple problem of hypokalemia and hypertension. Any questions from the audience? Okay. I think if there are no further questions, we'll move on to the next presentation.